Pulmonary function testing. Danish Thamim MD. Pulmonary and critical care medicine. Indications for pulmonary functions. Evaluation of a pulmonary symptom. Evaluation of smokers without symptoms. Evaluation of workers exposed to hazards. Quantification of impairment. Evaluate response to therapy. Preoperative assessment. Disability evaluation. Timeline of cigarette smokers that develop obstructive lung disease. Types of pulmonary function tests. Spirometry. Lung volumes. Diffusion capacity. Maximal respiratory pressures. Maximum voluntary ventilation, MVV. Arterial blood gases. Pulse oximetry. Bronchoprovocation. Evaluate gas exchange, diffusion capacity and ABG. Lung volumes diagram. Volume if cannot be broken down in smaller subcomponents. Lung volumes and capacities. 4 volumes. VT. IRV. ERV. RV. 4 capacities. VC. IC. FRC. TLC. General approach to interpretation. Is the test interpretable? Are the results normal, or abnormal? What is the pattern? What is the severity? What does this mean for the patient? PFTs cannot make a diagnosis, however, patterns can help narrow differential diagnosis. Acceptability criteria for spirograms. Free from artifacts. Cough or glottis closure during the first second of exhalation. Early termination or cut-off. Variable effort. Leak. Obstructed mouthpiece. Satisfactory exhalation. 6 seconds of exhalation and or a plateau in the volume time curve or reasonable duration or a plateau in the volume time curve or the subject cannot or should not continue to exhale. Good start. Extrapolated volume is less than 5% of FVC or 0.15 liters, whichever is greater, or time to PEF is less than 120 ms, optional until further information is available. Repeatability criteria. After 3 acceptable spirograms have been obtained, apply the following tests. Are the 2 largest FVCs within 0.2 liters of each other? Are the 2 largest FEV1s within 0.2 liters of each other? If both of these criteria are met, the test session may be concluded. If both of these criteria are not met, continue testing until both of the criteria are met with analysis of additional acceptable spirograms, or a total of 8 tests have been performed, or save a minimum of 3 best maneuvers. Spirometry. FVC, forced vital capacity, maximum volume of air that can be exhaled during a forced maneuver, after maximal forced inspiration, TLC. FEV1, forced expired volume in 1 second, volume expired in the first second of maximal expiration after a maximal inspiration. FEV1/FVC, FEV1 expressed as a percent of FVC, a clinically useful index of airflow limitation. Spirogram. Predicting normal values. Depend on patients' height, age, gender, racial and ethnic background, weight and BMI, to a lesser degree. Reference standards. Percent predicted as normal range. Results are expressed as percent predicted of a predicted normal value of a person the same age, sex, and height. FVC and FEV1. Normal range is FVC 80 to 120%. FEV1 80 to 120%. FEV1/FVC greater than 0.70 of predicted ratio. Obstruction versus restriction. If the FVC and/or FEV1 is below normal, the distinction between obstruction and restriction is based on the FEV1/FVC ratio. NIH/WHO, Gold Guidelines recommends using ratio below 0.70 for the diagnosis of COPD. ATS-FEV1/FVC ratio 0.08 to 0.10 less than the predicted ratio. Obstructive lung disease, emphysema and chronic bronchitis, cystic fibrosis, asthma, bronchiectasis, some interstitial lung disease, combined. Restrictive patent normal or elevated FEV1/FVC ratio. With a low FEV1 or FVC suggests restriction. Lung volumes are needed to confirm. Some patients with asthma or COPD may have this pattern, pseudorestriction. Restrictive lung disease. Rating of severity may be based on statements such as from the American Thoracic Society, ATS. Obstructive pattern, FEV1. Restrictive pattern, TLC, lung volumes. If lung volumes not obtained, FVC. ATS/ERS standardization of lung function testing. Interpretative strategies for lung function tests, 2005. Classification of COPD by severity Gold Guidelines, 2009. I. Mild FEV1/FVC less than 70%, FEV1 greater than 80% predicted. 2. Moderate FEV1/FVC less than 70%, 50% less than FEV1 less than 80%. 3. Severe FEV1/FVC less than 70%, 30% less than FEV1 less than 50%. 4. Very FEV1/FVC less than 70%, FEV1 less than 30% predicted severe or FEV1 less than 50% predicted plus chronic respiratory failure, bronchodilator response. Must use bronchodilator with rapid onset. Albuterol. Lavalbuterol. Increase FEV1 or FVC from baseline by at least 12%. By at least 200 milliliters. Both values must be met. Help differentiate between asthma and COPD. If not responsive does not mean not to use bronchodilators. Flow volume loops. Normal. Upper airway obstruction patterns. Detect obstructive lesions in the major airways. Characterizes the lesion. Location of the lesion. Interthoracic. Extrathoracic. Behavior of the lesion in rapid inspiration and expiration. Fixed. Variable. Uncommon. Suspicion based on FVL. Different from obstruction of more distal airways due to asthma and COPD. Variable extrathoracic obstruction. Extrathoracic, above the suprasternal notch. Effects of forced expiration and inspiration in dynamic extrathoracic airway obstruction. Left, during forced expiration, intratracheal pressure, PTR, exceeds the pressure around the airway, pattern, lessening the obstruction. Right, during forced inspiration, when intratracheal pressure falls below the atmospheric pressure, the obstruction worsens resulting in flow limitation. Vocal cord paralysis. Goiter. Tumor. Levitsky M.G. Pulmonary Physiology, McGraw-Hill 4th ed., 1995, p. 50. Variable intrathoracic obstruction. Lesion is within the thoracic cavity, below suprasternal notch. Left panel, during forced expiration, the interthoracic intratracheal pressure, PTR, is less than the pressure in the pleural pressure, PEPL, worsening the obstruction. Right, during forced inspiration, intratracheal pressure exceeds the pleural pressure, lessening the degree of obstruction. Tracheomalacia. Intratracheal tumor. Levitsky M.G. Pulmonary Physiology, McGraw-Hill 4th ed., 1995, P50. Fixed obstruction tracheal stenosis/stricture. Bilateral vocal cord paralysis. Extrinsic compression. Levitsky M.G. Pulmonary Physiology, McGraw-Hill 4th ed., 1995, P50. Lung volumes. Lung volumes diagram. Volume if cannot be broken down in smaller subcomponents. Lung volumes in lung diseases. Diffusion capacity. Estimates the transfer of oxygen in the alveolar air to the red blood cell. Factors that influence the diffusion. 1. Area of the alveolar capillary membrane, A. 2. Thickness of the membrane, T. 3. Driving pressure. 4. Hemoglobin. 5. Carboxyhemoglobin. Diffusing capacity. Single breath DLCO measures the capacity of the lung to transfer gas. Patient exhales to RV, then rapidly inhales gas mixture with minute amount of CO. After 10 seconds breath hold at TLC, the patient rapidly exhales and the exhaled gas is analyzed to measure the amount of CO transferred into the capillary blood during the maneuver. Abnormalities of diffusing capacity. Decreased in conditions that disrupt the alveolar capillary surface for gas transfer. Loss of surface area, resection, fibrosis, emphysema, pneumonia. Reduced lung capillary volume, vasculitis, thromboembolism, primary pulmonary HTN, ILD. Increased diffusion distance, PAP, PCP. Abnormalities of diffusing capacity. Increased by conditions that lead to recruitment of pulmonary vascular bed and increase in capillary blood volume. Exercise, mild CHF, asthma. Or by increased amount of hemoglobin which binds CO. Pulmonary hemorrhage, erythrocytosis. Case 154 years/O male smoker PFT FeV1, 1.3 liters, 23%, FVC, 2.3 liters, 45%. FeV1/FVC, 56. TLC 98%. RV, 156%. DLCO, 30%. COPD diagnosis: very severe obstructive defect, severe reduction in DLCO. High RV. Air trapping. COPD, case 235 years/OF with SLE FeV1, 56%, FVC, 45%, FeV1/FVC 90. TLC, 48%. RV, 45%. DLCO, 23%. FeV1 increased by 4%, 0.1 liters, with bronchodilator testing. Diagnosis: severe restriction without significant response to bronchodilators. Severe reduction in DLCO. ILD. Pulmonary fibrosis, case 3. 45 years/O female with history of allergic rhinitis and dyspnea on exertion. FeV1 to 3.2, 70%, pre, 4.5, 100%, post-BD. FVC, 4.9, 70%, pre, 6.0, 85%, post-BD. Ratio -65% pre and 75% post. TLC, 6 liters, 100%. DLCO minus 100%. Diagnosis: mild obstruction with significant response to bronchodilators, normal. Normal lung volumes and DLCO. Asthma. Case 4, 76 years/O, male with weight loss and dyspnea, FEV1, 4 liters, 85%. FVC, 5.1 liters, 80%. Ratio minus 78%. TLC, 6 liters, 82%. DLCO minus 88%. Diagnosis: extrathoracic obstruction, normal spirometry. Truncated inspiratory limb of the flow volume loop. Extrathoracic obstruction.